Morning, everybody. From the thing, I thought it was 15 minutes, but it has been cut down to 10 minutes now. So I should be telling you about this. I'll be only telling you about there's no point telling you about the anatomy, which you all know. But what I'll be telling you is about the applied anatomy, which is of more relevance. Now, the aortic arch, we don't have to tell very much. We all know about it. It's important to know that the subclavian, which supplies the upper limb, terminates at the outer border of the first rib. So if you've got a skygram, you've got an X-ray, you can know exactly where the thing is starting and where the axillary artery is starting. As it goes, the axillary artery supplies the head of the humerus, and any sort of an injury to this will cause avascular necrosis, which we must keep in mind when there's an occlusion of this vessel or trauma to this vessel. Now, as the thing goes on, the axillary artery, we know it ends at the outer border of the teres major muscle. Now, from there, just as it starts, the brachial artery, we find it gives rise to an important branch, which is the profunda. Now, the profunda itself, like in the leg, can save the hand if the brachial artery is transected. So profunda also goes into the radial groove, which is at the back of the humerus, and any fractures in this, you anticipate that probably that vessel is injured and you may have a problem in the arm. Now, as it goes on further, the axillary artery, before this, the axillary artery, there are 2-3 important conditions because an aneurysm can happen. And how do you predict? Of course, there may be a pulsatile swelling, but there may be sensory loss because of pressure symptoms. We anticipate the patient may be hypertensive, he may have Marfan's, or they may be baseball pitchers. They have this thing generally present, an aneurysm of this place. Now, as the brachial artery goes on, it bifurcates just below the starting at the elbow, and it breaks up into the two, as you know, the radial and the ulnar. Now, this supplies, the important thing is if it is injured, it can give rise to Walkman's ischemic contracture. Now, as it goes into the hand, as I've told you, it has got the superficial and the deep arches. The superficial arch is mainly for giving, for sweating, and therefore regulating temperature. But the deep arch is important because sometimes if your grip is a lot and it is persistent, then in that case there is no ischemia. The reason for it, there being no ischemia, is because of this deep palmar arch. Now, the venous system in this thing, as you know, is formed by the cephalic and the basilic veins. And these two will unite together to form the axillary with the brachial vein. In fact, the basilic continues as the axillary vein and the cephalic joins it. These two, cephalic and basilic, are joined together at the elbow by the median cubital vein, which is the vein which you normally use for drawing blood. Now, one thing important putting central lines these days, it is not very easy sometimes. You have a lot of complications if you put the lines through the subclavian or you put the line through the jugular. You can have high complication rate. One thing important is in the delta pectoral groove, you go to the axillary vein and you can very easily, under direct vision, you can put in a central line, which is got no complications or hardly any complications compared to the other procedures. Of course, with the advent of your ultrasound and color Doppler techniques, it's becoming easier. But still, it is safer to put it in the axillary vein at the delta pectoral groove. There's nothing much to tell about the veins here. The arteries, as you know, the aorta breaks up at the level of L3, L4, and that is the landmark. As it goes on into the common iliac, the external iliac, it enters the leg at the inguinal ligament. The inguinal ligament lies at the head of the humerus. So if you see only the head, you know exactly from the X-ray where it is lying. As it goes on further, it gives rise to the profunda, which is in the femoral triangle. And profunda, as I told you, can save the leg even if the superficial femoral artery is occluded or transected. So it is a very important artery as far as the thigh, as far as the leg is concerned, because of the anastomosis. Now, one thing important, if the femoral is either occluded or transected, you know that there could be avascular necrosis of the head of the femur, and that is something which one must keep in mind. Sometimes you land up as surgeons doing a very high amputation because the patient presents very late, especially in our country. They come from the villages and they may have total injury to the leg. Now, in that case, you may find that the obturator vessels provides enough to supply the muscles of the medial aspect of the upper thigh so that they can cover the stump. In the popliteal fossa, you've got the popliteal artery, and that supplies the knee. And below, we have got the vessels which supply the leg, the anterior, the tibial, posterior tibial, and the peroneal. I'm sorry I have to rush through it because I thought there were 15 minutes, but there are 10. Now, the veins of the leg are the femoral and the popliteal, or the veins which are the deep system. The superficial system is formed by the long and the short saphenous. The long and the short saphenous, as you know, are involved in the varicose veins, and the deep system is important for DVT. And from DVT, what is more important is pulmonary embolism, which is life-threatening condition. Now, the head and neck, especially the anatomy of the neck, you've got the presence of the carotid, which breaks up at the level of C4 into the external and internal carotid. The internal supplies no branches in the neck and goes into the brain to supply the structures there, whereas the external supplies the face. At the carotid, there is the carotid body, which contains baroreceptors and chemoreceptors. Baroreceptors for regulation of the blood pressure. Chemoreceptors are for the regulation of breathing. Well, there's nothing very much to tell about these other ones. In the epidemiology, the definitions for the youngsters may be what is incidence and prevalence. Incidence is the newly diagnosed cases in a specified definite number of population over a definite period. Whereas prevalence is the number of cases, not new cases, any cases of that particular disease over, again for a defined population over a specified period, maybe 1 year. I'm sorry, there's got no specified period at any given time. Mortality, of course, has got a specified time and the number of patients dying. It does not include any new or old or anything, but it is just that. Now, what are the pitfalls of determining prevalence? It depends upon what are the parameters you take. Like if you take claudication, your estimation is normally 20% below. If you palpate the pulses and you take that as the criteria, then you are probably got an overestimation of 20%. The most diagnostic thing and the most commonly used are non-invasive techniques, which may be color Doppler, which definitely tells you and which increases your prevalence by 3 to 4 times because it is very accurate. There were studies which were conducted on the incidence of by using claudication as a parameter, and it was about 9.2 per 1,000. Whereas if you see the same thing, using non-invasive studies, it rises dramatically to 27.2 per 1,000 at about 70 years of age. So as you go and we have more investigations, the thing becomes more diagnostic. Another study which was conducted was the Edinburgh study. Again, if you see, they took 3 parameters, which were claudication, ankle brachial index, and ankle anterior index after doing the treadmill or in hyperemia. Using claudication, they found that the incidence was about 4.6, which rose to 17 when you went up to some more investigation, like using ankle brachial index, which rose again further to 24.6. So the same condition is rising depending upon these things. Well, thank you very much. Again, as I said, I'm sorry the time was more limited than I thought it was.